Thank you for being here, the final session. Maybe because it's extreme, you decided to stay. Unfortunately, I'm not wearing black nylon and Velcro. I'm not fast roping in with, returning fire and doing stuff like that. But I do want to thank Ali and Patrick and the organizers. I've been here before, trained with TBS Zermatt, world class. If you have the opportunity, if you haven't seen this, to go this afternoon and see their operation, fantastic, worldwide standard. And they come and they train, other military and civilian organizations in rescue. So just outstanding. There you go, fist bump. So, and I got a ride yesterday afternoon, so hell yeah. So I'm winning. But so how many of you work in urban environments? Okay. How many of you use pre-hospital ECMO? Okay, so this lecture is not for any of you. Okay, this is the rest of the real world who has to operate in different areas. I am a retired colonel, but I am by no means retired. My wife has prohibited me from using that term because I seem to find a lot of work, despite the fact that I spent 27 years in the military. Just some fancy titles there. But really, my passion is in education and training, and especially in the pre-hospital space. I am from the United States. This is kind of some of the stuff that I do, but I am from the United States and I'm a medical director. So just to understand our paradigm of EMS care, if you don't, we have paramedics. Generally, physicians do not go into the pre-hospital space. As an EMS trained physician, I oversee education, training, guidelines development, online and offline medical control, but we don't necessarily go forward to provide that care. When I was in the military, I had the privilege of being a medical director for about 11 years of my time for special operations medics, which are basically paramedic plus, so pararescuemen, special forces medics, Navy SEAL corpsmen, those type of folks who go out alone and unafraid. And so it is in that capacity that we developed this. So just by show of hands, how many people have heard the term prolonged field care? Good, there's a few out there. Has anybody listened to the Prolonged Field Care podcast? Few people. I would highly recommend that. It comes out about once a week. It is downloaded about 18,000 times. You can find it on Spotify, iTunes, that type of thing. Fantastic. The one that was just published this past week was a trauma surgeon who found himself as a patient in a mass cal, and he recounts his experience. It's just fascinating. I mean, just if you can overlook the four-letter words that he uses to describe it, his passionate description of what it's like to be a patient touches on many of the psychological things as well as the technical terms. Fantastic podcast, Prolonged Field Care. So anyways, I do advise. I'm a consultant to the Joint Trauma System. So I worked for Colonel Shackelford when she was the chief there. I also advise a research team. I'm not a researcher, but I'm the operational conscience for the researchers. So I explain why we're doing the research we do. I am, as I said, an EMS medical director for a rural county. We are currently working on getting whole blood. We do look at, using the best practices in the military, but when I talk about this, it's going to be military-based. So when I use the terms T-Tri-C, T-Triple-C, TC3, that's tactical combat casualty care. If I use the term DCR, damage control resuscitation, all in a pre-hospital sense. And then I also we have a small training company where we train special operations medics and non-medic teammates in how to take care of complex medical presentations. And also we have a medical education company, which I'll touch on briefly. So my objectives today are here. And this is going to be a tremendous amount of information, a small amount. So I apologize if you don't really understand or have heard about prolonged field care. I'm not going to get into that too much, but suffice it to say it's something that we've been developing in the pre-hospital space, started in the military, but now it's expanded to the non-military and international communities. I'm going to talk about PFC, civilian education efforts, and then I'm just going to ponder on what I'll call the future of PFC as we see it from a U.S. military standpoint, looking at conflicts in Eastern Europe, looking at conflicts potentially in the Pacific and whatnot. So I want to talk about the past. So back in 2013, I was the medical director for the 10th Special Forces Group, based out of Colorado. I had 140 Special Forces medical sergeants. So our special operations command, with all of its enablers, is 73,000 people, which is bigger than the militaries of many. That's just the special operations. We have 7 special forces groups, Green Berets. You might have heard the term Green Berets. And I had 140 medics that I was a medical director for. And they had been going for a decade to Iraq. We were really, really, really good at TCCC. We were really good at the first 20 to 30 minutes of care, almost to the exclusion of any other medical care. And then we called for medical evacuation, and we heard from some of the numbers, as Colonel Shackelford talked about yesterday, that we were able to pick them up and bring them to a surgeon within 1 hour. But then what happened was they retasked our entire group, and they said, okay, great, you've been going to Iraq. We're drawing down our operations in Iraq. Now you're going to focus on the continent of Africa. And my medics were coming back to me, and they were showing me pictures like this. And if you can imagine providing medical support for the motorcycle crash that was described in the last hour, how do you provide medical support for that? How do you recover that person? How do you bring them back? How do you evaluate and resuscitate them? And sure, my medics were very highly trained. As we say, a mile wide and a quarter of an inch deep, or 3 centimeters deep, or however you look at that, right? So, but the bottom line was they had been trained in some of these skills, but they just hadn't practiced them in a long time. And so although prolonged field care is not necessarily a new concept, we had to reframe how we take care of serious and critical casualties in resource-limited environments beyond the golden hour. And again, I refer back to Colonel Shackelford's talk where she actually showed that picture where they said 30 minutes and time, and then you saw that one over the side that said, and if you can't get to a surgeon, prolonged casualty care. And they're essentially the same, prolonged field care, prolonged casualty care. I'll cover that here in a sec. And then when they were in Africa, and this is where a surgical team was, so the surgeon, a anesthetist, an emergency physician, and they realized that there was a lot of weather coming in. So even if you had highly trained individuals, if you had a complex patient, it would be very hard to move them, especially when you had sandstorms, especially when you had weather events. And if they called for an evacuation, they had to call back to Germany, and they said, sure, we'll send you an aircraft. It'll be there in 17 hours. And our medics and our small surgical teams were like, well, what are we supposed to do during that time? So prolonged field care is really looking at what do you do when you get to the end of your guideline, your protocol, your clinical practice guideline that's published. How do you take care of a patient after that? And so we get into crew resource management. We talk about teams. We talk about cognitive load. Most importantly is how do you deal with complex patients when perhaps you don't have everything that you would like to take care of them? I don't know if we've coined the term tyranny of distance, but this really put it into perspective. So when we first looked at prolonged field care, we were looking at our operational paradigm was the country of Afghanistan, overlaid on the United States, because we can conceive that, but then we were putting people in the middle of nowhere, literally, in Africa, and asking them to provide medical care. And again, this just shows the concentric rings that said, if I were to call Germany and ask for medical evacuation, and the crew was on the aircraft, and the aircraft took off the minute I called, that's how long it would take to get to where our teams were. And so we had a real problem with distance and time. And the bottom line was we were putting our medics out there and saying, hey, good luck with that. I hope no one gets hurt. Now, luckily, they weren't being shot at and blown up and all of that necessarily, but there were a lot of circumstances that they were concerned about. And although we used Africa as that picture of time and distance, what we realized there are other places in the world. So when I was deployed to the Philippines in 2011, the mountains in the background in the upper right there, let me see if I can figure out how this works. Yeah, the mountains back here is really where our base was. This is Mindanao, so the south part of the Philippines. And when you were flying on helicopters, you'd literally fly over tens or hundreds of these small islands. And the bad guys don't necessarily hang out next to where the hospital is. They're on those small islands, so you have to go and you have to find them. But if you can imagine a maritime team, Navy SEALs, U.S. Marines, would have to go out probably by watercraft and maybe come on with a small inflatable boat, and they would have to secure their patient. And how would they move them back practically? How would you deal with that? So we're not just talking about the tactical combat casualty care, but then how do you stabilize? How do you move? How do you ensure pain control and everything else? And then as our medics were sitting there, they realized that, deployments are not as exciting, despite what you read in books, and see in the movies, right? 95% of the time, it's boredom. And so if you take a bunch of 18 to 20-year-olds, even without alcohol, they'll figure out ways to do just dumb things, right? And nobody really, even though it's prescribed, in procedures or standard operation procedures that you must wear a helmet when you're driving an ATV or a four-wheel vehicle, how many of them do you think to do that? It doesn't look cool. They will have their eye protection on because they have Oakley sunglasses, and they look cool with that, and it looks good in the pictures, but they will not wear helmets. And so what we found out was that they will do a lot of dumb things. And of course, when they're bored, they might decide that they're going to jump off a compound with their skateboard and see how cool they look, and maybe get it on YouTube and all that. But the bottom line was our medics thought about not the general, as we call the ass clownery that our soldiers would do, but they thought about, well, I'm in Africa. What about snake bites? Tactical combat casualty care doesn't tell me how to take care of that. What about electrocution? What about TBI, pelvic injuries? A negligent discharge. It means when somebody fires a weapon they don't mean to. Because we're down there, we're training, for instance, African militaries. But when you hand them a loaded weapon, that could be a bad situation. And then just simple things like stomach pain. How do you diagnose stomach pain? We do it all the time in the hospitals, but how do you do that with limited labs, resources, and certainly a lot of time? And as we looked at this and developed it in the military, and I was retired, moving out of the military, I realized there are a lot of non-military contexts for this. The upper left picture was from Australia, and so there's a huge amount of distance and a huge amount of time. And although you have these population centers, you do have patients that are going to be outside those population centers. And so we talk about prolonged field care. I would posit to you, in the United States, 18% of our population lives in what we consider rural and frontier areas. Is it the majority? No. But there's certainly a lot of ground and a lot of people that still need to be covered. And then you have incidents, so maybe you're not that far away from physically from a medical center, but you may find yourself, and we see this in Colorado, you probably see this in Zermatt, where things just get locked down, lines of communication are locked down. So physically you may not be that far away from a medical facility, but you're going to have to sit on this patient because of traffic accidents, because of weather incidents. And then search and rescue, and this is very similar right here. This picture is very similar to where my ambulance systems work in this rural environment, a lot of dirt roads, that type of thing. So when we were observing this problem, we decided, and again, these aren't necessarily new concepts, so what we needed to do was we needed to define the problem. And so we had to come up with a definition. So we got together, when I say we, it's me and 140 of my closest friends, because at the Special Operations Medical Association meeting, by the way, you're all invited. I know it's almost as nice as Zermatt. We meet in Raleigh, North Carolina. It's very flat. It's a little bit warmer. There's a couple nice Walmarts. So if you want to go see Walmart, like the people of Walmart, you can go and see them firsthand. But we all get together there in North Carolina, and really, that is where Tactical Combat Casualty Care started, was the Special Operations Medical Association. That's where PFC started. That's where Austere Resuscitated Surgical Care. It's a think tank of people coming together to share best practices and come up with that. And although it is the Special Operations, you don't have to be Special Operations to go there. Clearly, about half of the folks there are non-military, a lot of government agencies. We have a ton of people that come over from Europe, Australia, New Zealand. Great meeting. But anyways, we came up with this. So we had to come up with a definition. We adopted what the NATO Special Operations Forces had come up with just that same year in April. So we said field medical care. So again, this is out of hospital, pre-hospital. Applied behind doctrinal planning timelines. So everybody trains and equips themselves to take care of patients, but it's doctrine. We had to choose a level, Special Operations Combat Medic, essentially a paramedic, in order to decrease both patient mortality and morbidity. So although we might put on a tourniquet to save somebody's life in the first 15 minutes of bleeding, what does that tourniquet do to a patient in 6 hours or 8 hours? We might hear about that from Michael in the next hour. But bottom line is, there's a significant amount of morbidity we have to get at. And most of our trauma looks at mortality, but we're actually looking at how do we also decrease morbidity? Utilize limited resources at an appropriate level. But as one of my colleagues said, treating a patient needs to be somewhere else for longer than you want to. How do you deal with a sick or critical patient with limited experience, limited credentials, or limited supplies? And so we were having this problem, we were describing it, and actually, Colonel Shackford, when she was chief of the Joint Trauma System, said, hey, I think we've got some scientists that can help you with this, because we wrote clinical practice guidelines, or CPGs, for our deploying general surgeons on how to do best practices of trauma surgery. In fact, they had written 44 of them, but they were all focused on surgeons. Then we wanted to look at the pre-hospital side. And so the pre-hospital side, they actually got them together, and we wrote clinical practice guidelines. Burn wound management. Great, you don't have a burn center. How do you deal with the burn wound? Ocular injuries. Life, limb, or eyesight. Well, I'm not an ophthalmologist, not an optometrist. I know people have two eyes and they see out of them, but what when they can't see and it's red and it hurts? How do I deal with that in an austere environment? And then analgesia and sedation management. These are not comprehensive. These are written for the gaps of austere care. I have a burn, 28% total body surface area burn. I know I need to resuscitate, I know I need fluids, I know I need to do some kind of burn care, but I don't have a burn center and I can't move them. How do I take care of that? There's a gap there between hospital-based best practice and what can we do with limited resources. And that's what we tried to get after. We wrote about, I think, 12 or 14 of these: nursing care, documentation, all of those things, relatively simple, but it tries to encapsulate how you would take care of these patients in resource-constrained environments. So that was the past. The present, I would say, is about 2020 to 2025. So what happened then? The Joint Trauma System took the prolonged field care, I'll call them the working group, and they became a subcommittee under tactical combat casualty care. And so what happened was we said, this is great for special operations, but now we need to use it to the rest of the military, and we're going to publish guidelines. And so we got the rest of the military together. Army, Navy, Air Force, Marines, Space Force wasn't invited. They weren't around yet. They're kind of weird. So, small, focus on other stuff. All the people that like to watch Star Trek, Star Wars, send them over to the Space Force. They all get together. They talk about nerdy things like that. Anyways, taking a lot of heat off of our Air Force, by the way. So I just point to Oliver because he's an Air Force pararescue man. So Space Force has kind of become, a lot of jokes. Have you seen that movie, Space Force, with Steve Carell? It's fantastic. It is so accurate. Fantastic. After you download the podcast and listen to them, watch Space Force. It's fantastic. Okay, so anyways, PCC. So this was, and so we got everyone in the room, and the Navy said, well, we don't work in the field. We don't do prolonged field care. That's an Army and Marine thing. I joined the Navy so I don't have to go into the field. And so they said, we need to call it something different. So this began a little bit of a split and confusion with everyone else. So prolonged casualty care became prolonged field care, but for the masses, I will say. And the big assumption here is that you only are trained and equipped for tactical combat casualty care. And I would submit to you that this made it very military specific and didn't apply as much to non-military or civilian context. If you pick up the original clinical practice guidelines, I bet you'll find some real pearls in there that you can use. The PCC guidelines tend to be, I'm not going to say dumbed down, but they're a bit more like a protocol. But anyways, same basic information, just more military specific and more focused on only tactical combat casualty care and what do I do next. We have a draft completed. Sometime in 2025, we should come out with version 2.0, hopefully very, very, very soon. Okay, military guidelines, where can you find them? There is a website called Deployed Medicine. So if you want to know where the guidelines are right now, Deployed Medicine is run by the Joint Trauma System. You can download it onto an app onto your phone, and you can see what are the latest guidelines. You can download clinical practice guidelines. So Deployed Medicine is actually a very good place to go to see what are we doing next. When an update is published, it goes on to Deployed Medicine. It doesn't look like a military website per se, but it is run by the Joint Trauma System. But it's open to everyone, unless you're in a country that blocks it, as in the case of Ukraine. But then Ukraine basically had a nonprofit organization that set up a Ukrainian website, translated the entire thing, and now they're being used by law, tactical combat casualty care guidelines. We also put out a PCC curriculum, how to teach it, but it's only the backbone of learning objectives. It's not a course, it's just an outline. So if you got onto Deployed Medicine, you'll see a tactical combat casualty care course. This is not a course, it's just the outline. Okay, great, you're not in the military. You may not be deploying. What can you do? And so a big gap that we had over the last 10 years is this is great, Sean. You're telling us about these wonderful clinical practice. How do I train for it? How do I think I'm interested. I'm going to go as an NGO. I'm on a deployable team for disaster readiness, or I work in a rural system. I work in our national parks. I work on the border patrol. I work in all these different places. This sounds great, and I think I can use it. How can I use that? So over the last few years, we actually developed a nonprofit organization. If you understand or have heard of the committee of TECC, Tactical Emergency Casualty Care, what they did was it was a group of tactical, non-military EMS folks that got together and said, hey, we're going to take the military guidelines and we're going to make them into a civilian or non-military context. What we did was we formed a nonprofit organization and we developed a 40-hour course called Austere Emergency Care. It's an introduction to this operational context. It's an introduction to some of what we think are the best practices. And we actually have started teaching it in Europe, as well as the US, as well as New Zealand, as well as Australia. And so it's a 40-hour course. It's a continuing education curriculum. It will not make you an expert in PFC per se, but it will open up your providers to this operational scenario. And when we first did this, we took a military course that we were teaching our special operations and we brought it to our civilian EMS folks. And we said, what do we need to change? And they said, don't change anything. This is fantastic. We can absolutely use these guidelines before. And there's some people in the room that have taught it. Patrick is actually an instructor of it. He came up to Norway and helped teach. And I think what it does is it really just gets you to consider, it opens up the aperture. And I've always said this, if you take type A smart people and you show them a new operational scenario, a new clinical context, they will start to think about, okay, how will I use this in my setting? What would I do if I was in that situation? And in fact, people go back and repack their aid bags, repack how they think about logistics, repack because they start to think about, if I were in a situation where I can't move that person, that's what we need to do. So austerecare.org, that's our website. Those of you who said the PFC podcast, we took the Prolonged Field Care Working Group and we just reflagged them as a Prolonged Field Care Collective, brought them up under our nonprofit organization. Again, we run the website, prolongedfieldcare.org, as well as the PFC podcast. It gave a mechanism to support these gentlemen who have been working for the past decade to bring education and training, I will say, to the masses. And again, the podcast downloaded 120 countries. We can track this over YouTube, and 18,000 downloads per episode. I would highly recommend, if you have even a passing interest, to check it out. They're on, I think, episode 190-ish right now. So there's some really fascinating stuff in there. But I would challenge you, anything that you want to know about how you use ketamine, what's the deal with midazolam, how is it, what kind of surgical procedures, how do I pack an aid bag, tell me some stories about this. You can find it on this podcast. So. And it's 5 stars, not like the hospital before where it was like 4 stars. So, and then Paul just recently retired from active duty. Both these guys are Special Forces medical sergeants. Dennis is also a nurse, but fantastic guys to work with. So what's our challenges? We're experiencing in the U.S., it's not the same, obviously, anywhere else, what we call the Walker dip. Alistair Walker described in the interwar periods, we tend to forget all of our lessons learned that we gained during wartime. Luckily, we're not taking casualties. Luckily, we don't have as many people deployed right now. But what that does is it kind of refocuses resources away from education and training. So we are struggling, I would say, in the U.S. military to even keep up with standards of tactical combat casualty care. We are exploring damage control resuscitation, or the resuscitation of whole blood. We are standardizing how to do walking blood banks. That is not universal across the services. Our special operations forces, who are still deploying, our special operations forces are good at it, I would say, for the most part, but our general purpose forces are not that good at it. We do believe, I think, with the data, that giving whole blood in the first 30 minutes, as you heard yesterday, could extend the quote-unquote golden hour. It's going to extend it a little bit, but I think we're going to see more survivors. Anecdotally, on the civilian side, we are seeing more survivors survivors of trauma, making it to the hospitals. In the changing realities of warfare, we're studying what's happening in what we call large-scale combat operations. So what's the future? When we wrote this, we had a paradigm patient movement. We're talking about, okay, damage control resuscitation, that's going to be fundamental. How do we resuscitate in a resource-limited environment? We would have limited logistics. We gave people the permission to use telemedicine, so telling type A medics that are supposed to know everything when they leave, tell them it's okay to call up and ask for help. That's important. And then we have known mortality estimates. As we look at what we'll call large-scale combat operations, the conflict in Eastern Europe, the Indo-Pacific, from our perspective, I would submit that many times they're stuck in tactical combat casualty care. They're stuck in the care under fire phase. If you're in the ground, in a trench, you're being watched by drones, it's extraordinarily hard to even begin to move somebody out. Forget about doing advanced medical care. It's only when you get to the stabilization points, which we'll hear more about, I think. When you get to stabilization points, then you can start, I would say, probably practicing medicine with medically trained individuals. Resupply is a major planning factor now for the US military. We say, okay, if I can't move patients back, how am I going to resupply folks? We may not have the communication we thought we'd have when we started to explore the uses of telemedicine. And we're looking at something right now that we're exploring called expectant casualty care. The reality is if I can't move critically injured people, people are going to die. And they're never even going to make it to the hospital. Expectant is a triage category. We got to get better at triage, and we got to make some really, really tough decisions. But we're putting those decisions on the 19 or 21-year-old medic who will then have to deal with the repercussions of those decisions. I think, as experienced folks that have gone overseas, the JTS, Joint Trauma System, I think that we need to provide some kind of guidance to the trainers and the medics as to how they're going to deal with those literal life and death decisions. And it's our obligation, I think, to be able to put those out. We are having some discussions right now. We're starting to talk about this. We're starting to present this. But expectant casualty care, I think, is going to be a major issue in upcoming conflicts. So some of you might know Geir Strandenes. He's a passionate supporter and founder of the Thor Group, along with Phil Spinella. And I think that this is true. There's a lot of debates that go on up in Norway over in the bars and whatnot. And he said, hey, you can be entitled to your own opinion, but you're not entitled to your own physiology. So the bottom line is it doesn't matter what your operational context. It doesn't matter where you are or what you show up with to provide care. Physiology is still physiology. And as I used to tell our commanders, just because you're in Africa does not mean that you bleed slower. We still have to support physiology if we're going to take care of serious and critical casualties. So the future of PFC comes back to, and you've heard this many times, master the basics. Prolonged, it's in the word, field care, prolonged means that you will have to manage a patient for hours, if not days. It's great to discuss the cutting edge while we're all here, relatively well rested, have caffeinated, pretty good temperature, maybe a little bit warm. It's easy for us to debate and talk about how we're going to take care of a patient, but try on the 14th hour with a team, cognitively loaded, tired, taking care of a patient. That's really what we're dealing with. You're going to fall back on your level of training. You're not going to rise to the occasion. You're going to fall back to your level of training, and so mastering the basics is absolutely where it is. The thing that makes special operations special is not that we have cool gadgets. It's not that we have cool technology. It's that we train the basics over and over and over and over again. And we do it in the dark, and we do it in the cold, and we do it on the side of a mountain, and we do it out at sea, and we just train over and over and over again. But mastering the basics is going to be key. And so what are the basics? Tactical combat casualty care, or TECC, then remote damage control resuscitation, the timely administration of blood for resuscitation, because generally we're dealing with trauma. Prolonged field care is generally trauma management. I would say out there that there is continuing education. I'm a little bit biased with the Austere emergency care curriculum, mostly because I wrote it with a couple other people. But the bottom line is there are pre-hospital provider training for this. And I would say look at the list. I didn't get into the essential capabilities. We listed 12 capabilities that need to be mastered. And it wasn't based on diagnostics. It was based on you need to be able to have an airway. You need to be able to oxygenate and ventilate. You need to provide nursing care. You need to be able to package a patient to move them. And so those are essential capabilities. So I would tell folks if they want to get better at it, think about what you're not good at and how you may be able to train on that. Okay? I would submit to you that PFC is the what you will do in these situations. How you will do that will be based on your operational situation. So if you're flying in a rescue helicopter, that's how you will provide this. If you're out at sea rescuing somebody, I'm pointing to Patrick here because he's out at sea now in Ireland, the operational situation may dictate the tools that you use, but the what you're going to do is prolonged field care. And I would say if you subscribe to tactical combat casualty care and some of the science that the Joint Trauma System has put out there, I would invite you to look at the clinical practice guidelines for austere environments and consider where that may be helpful based on your context of care. So in summary, operational need wasn't, we had a hobby, we had to do this for US SOF. There are scientific peer-reviewed guidelines that are out right now. I would submit to you, though they were written for the military, they were written for the US, that the CPGs, clinical practice guidelines, can be instituted into your practice, especially if you have some of these situations I talked about. There are continuing education out there. And I'm just going to say, as we observe some of the restricted movement and what's going on in Eastern Europe and perhaps in the Pacific theater, I am going to say future warfare and operations decisions may limit any good medical care. And the enemy always has a vote, and operations can overcome what we'd like to do. But practicing your best practices in austere environments will absolutely open your aperture and get you thinking about how you might do this. So that's what I have. That's the website that Paul runs, prolongfieldcare.org. The website of our nonprofit is austerecare.org. And I don't know if we have time for questions or discussions, but that's what we got. Thank you.
Thank you. We do have some time.